will present a clinical case. We will discuss the several treatment options of this case. And then personally I will discuss which option we have chosen and why and what does the expert say about our decision, and will elaborate. I'm very pleased to have a very good expert on the topic, Professor Weber Karsten. So let's start. It's a very clear-cut, I hope so, a clear-cut case. It's post-cardiac surgery patients. It's a 70-year-old male. He's being admitted to your ICU after elective cardiac surgery for coronary bypass. Medical history is not really spectacular. He has COPD and some hypercholesteremia, and extra information from the patient's file, which might be useful. He has BMI of 23 and glycolated hemoglobin of 5.8, so which is in a normal range. He's admitted to your ICU. He's an intubated patient, hemodynamically stable, as you can see, and with medication which you would expect from cardiac surgery patients. You take the first arterial blood gas. You see the ventilation, the PO2, PCO2, good saturation, lactate bicarbonate, hemoglobin of 9.1. But the thing we want to discuss today is this one, the last one. It's glycemia. It's 150 milligrams per deciliter. So what do you do? So first, there are three options which we like to discuss. Nothing, because it's only 150 milligrams per deciliter, and I only give insulin when glycemia is above 210, which is the renal threshold for glucosuria, and I want to avoid hemodynamic instability. Second option, nothing, because the current guidelines just advocate to tolerate hyperglycemia until 180 milligrams per deciliter, or are you a believer and you say, well, I start insulin therapy already, since I want to target strict normal glycemia, defined as 80 to 110 milligrams per deciliter. So who would like to choose option number one? Okay, option number two, the majority, and who would try three? So only one. That's nice, because it's also coming from Leuven. So why? Well, first of all, tolerating severe hyperglycemia, so it's very nice to see that nobody chose the first option. It has been clearly shown, and there's a clear consensus in the literature, that it's detrimental and should be avoided. But indeed, option two, and I think therefore the most people have chosen option two, advocate to keep glycemia between 110 and 180 milligrams per deciliter. This was mainly due to the results of the NICE-SUGAR trial, as most of you know. So, why option 3? Well, based on the available data, strict normal glycemia is still recommended, especially in surgical critical patients. Because the NICE-SUGAR trial, which if you read the literature more closely, didn't include a single cardiac surgical patient. And based on the pathophysiology, why glycemic control should work, it's to be believed that indeed there's a difference between medical ICU patients and surgical ICU patients. Concerning cardiac patients in particular, 80 to 110 milligrams per deciliter is the only evidence-based glycemic target.
Thank you. Thank you, Steve. Well, as you have seen, we have an ongoing debate. How high should the sugar be? The majority of you said, well, we at least limit it below 180 milligrams per deciliter. Only one said 110 to 80. At least, and this is undebatable, keep and limit the sugar below 180. This is recommended. But I still want to go in the discussion a little bit about how tight should we control sugar. Well, you all know these data from the Leuven trial, and you do know especially ICU patients who are treated longer on the ICU, they benefit from tight glycemic control. However, in these patients were in the majority cardiac patients, and in our case, we again look on cardiac patients. And if you go through the literature, it's a very old truth that controlling blood glucose as tight as possible, these are data from 1987. Well, keep the blood glucose as low as possible. This is associated to improved outcome. And if we go on further, we can see from 2010 in a retrospective analysis that as much you control your glucose level, also in these patients, as more they will improve. However, in these retrospective analysis, they could not show, in the multivariate analysis, they could not show that, that just fixing the blood sugar from 80 to 110 would improve. However, taking the blood sugar down was associated with improved survival. The truth is probably, or the answer is probably, we cannot, we have a very good literature for cardiac surgery patients. And maybe in these patients, it is fine to go and control for 80 to 110. We have a huge body of evidence for these patients. But we cannot go all over the patients, especially if you have diabetic patients. It's clearly shown that tight glycemic control in diabetic patients would not improve outcome, but maybe give harm to the patient. So the answer at the moment will be what glycemic control to what patient. Well, if you look why at all control for hyperglycemia, we have to know hyperglycemia itself is a pathogen. It increases the risk of infection. It does have pro-inflammatory action. We have hypercoagulability. We have ultrastructural damage in the mitochondria. So there's no doubt that hyperglycemia itself is a pathogen, especially in our ICU patients. And if you again look, what can you do by treating hyperglycemia, by giving insulin, you really can see that and it's not decided, is it a reduction of hyperglycemia or is it giving insulin? However, these both situations interact with each other, and you are able to reduce reactive oxygen species by giving insulin and controlling for hyperglycemia. You're, for example, able to reduce pro-inflammatory cytokines. So no doubt, keep the sugar as tight as possible. However, avoid hyperglycemia. Hyperglycemia per se also have the tendency, or we do know from newer data, that it will promote organ dysfunction other than the metabolic organ. For example, the brain. Hyperglycemia in this critical patient, this is nicely shown, is leading to impaired, for example, to impaired astrocytode reactivity, increased microglia activation, and so on. So hyperglycemia induces oxidative stress and is a pathogen. And controlling by giving insulin may reduce these entities.
Thank you very much. So again, you're back at the bed with the patients. So first of all, you have clearly demonstrated that above 180 milligrams per deciliter is not good. But then again, if you're giving insulin, the second question that easily pops up, do you start nutrition? It's an elective cardiac surgery patient. So no, I don't give any calorie. Second option, well, yes, I start some enteral nutrition if possible, and I give some parenteral dextrose in the form of glucose 5%, and I will target 40 or 60% of the daily caloric needs calculated on sex and ideal body weight. Or third option, yes, I start enteral feeding with parenteral nutrition, and I will target 100% of daily caloric needs. Or fourth option, yes, I only give him high doses of glutamine. So who are in favor for the first option? Okay, nobody. Second option? Okay. And third option, full feeding? Only one. And who will only give glutamine?
Can I ask a question?
Yes.
What's the trajectory of this patient? Is he ventilated or not?
He was intubated and he's ventilated.
And what's the trajectory for getting him off the ventilator?
How do you mean with the trajectory?
Is he likely to get off the ventilator tomorrow
He's
morning?
likely to get... Yeah, normally he's an elective patient, so he's likely to get
off the ventilator tomorrow morning?
True. So it's an
Okay.
elective cardiac surgery after
Then,
coronary.
then I vote for one.
For one,
Yeah.
okay. Well, read it.
Yeah. This is a very good question. We are coming to it.
Okay. So, first of all, we chosen for second option. So, but the fact that nobody chose one from the audience, but indeed there are other persons in the room. Well, first of all, why do we feed our patients? It's actually the most logical question we should ask, since we want to counteract the catabolic response associated with critical illness, which is mostly the case in severe, prolonged critical illness, in order to prevent the wasting syndrome associated with this pathology. But, as has been clearly shown in several reviews, this approach is very little evidence-based, to be honest. In observational studies, they are merely observational, early enteral feeding was associated with a better outcome, but merely an association, so no causative effect. However, large high-quality RCTs showing any outcome benefit of early provision of enteral or parenteral nutrition are actually lacking. So in conclusion, there is no clear evidence to feed our patients from early on in the ICU, so option 1 might be the correct one. So there is no data, so we tend to feed our patients enterally, but if you say, I will feed our patients, what are the possible pitfalls? Based on several reviews and nicely performed RCTs, showing that targeting 100% of daily caloric need in the early phase, so full parenteral nutrition, is not beneficial and possibly even harmful. So that, in any case, should be avoided.
Well, what is the pathology behind? What we really do know from perioperative patients, also intraoperatively, patients who are going to a procedure like cardiac surgery, they develop severe insulin resistance. This is what happens within hours. And this is also related to the amount of surgery these patients get. So the questions, and if you think about insulin resistance, it's hard to talk about giving nutrition. If the patients are not able to metabolize the nutrition, it's a really question why to do it. Well, there has been some investigation, why are these patients insulin resistant? Well, the insulin receptor, from the most of the papers we do have, the insulin receptor is working. And it's also working down to AKT, so one of the major parts in the insulin signal transduction. However, they are insulin resistant, and it may happen somewhere down here. And it is related to protein degradation and suppression of protein synthesis. What we do know from own investigation is that the insulin-resistant patient cannot be stimulated, even if you give very high doses of insulin and substrate, which has been done during this insulin clamp studies. So the critically ill patient and the insulin-resistant patient, the metabolic situation cannot be improved by insulin and by substrate. Well, moreover, we do know that proteins that degrade the muscle are upregulated very early, within a few days of critical illness, and this is looking like that you lose protein. And we don't have any idea whether it's possible to capture for this protein degradation by giving nutrition. There's a nice study from the Leuven group that investigated the effect of intensive insulin therapy on MRF and atropine, which are two proteins that regulate protein degradation. If they're upregulated, well, protein will be degraded. However, insulin could not suppress the activation of these two proteins, and this could be also shown in this sub-analysis from patients of the EPINIC trial. You know, we had a group with early feeding, early substituted feeding, and one group with late enteral feeding. And as you can see, it didn't do any difference to the muscle, and especially it didn't do any early feeding didn't do anything in comparison to late feeding, didn't do anything in suppression of MRF and atropine 1. So it's clearly the question: how much should we give in these patients? But what you said, I think it's very right. You have to look on the patient. What kind of patient do we have? This patient, and you couldn't know, he's going into intensive care, he develops pneumonia, and so on and so on. Well, the patient can be extubated very rapidly, and there's no reason not to start with a slide nutrition then.
Thank you very much. So Indeed, during the stay in ICU, things become more complicated. It was difficult weaning because, of course, it's to be expected to be, since elective surgery, to be extubated quite quickly. There was also an increase in inflammation parameters, more as you would expect, and the thorax picture showed an image-compatible lobular pneumonia, which was indeed, so the hemocultures were positive for Streptococcus pneumoniae, for which proper antibiotic therapy was initiated. But at day 5, so your physiotherapist do the rounds, and patient is still at the ICU, so not expected, and he receives at that moment hypocaloric, 40% target, around 40% of daily caloric needs, enteral feeding, no parenteral feeding was given. Your physiotherapist informed that your patient developed muscle weakness, an MRC sum score of 45, which shows your patient is weak. So what do? You say, well, obviously he needs more food because he's getting weak, so you increase the caloric intake to 100% of daily caloric needs. You say proteins are good for the muscles, they're broken down, so you try to administer supplementary proteins because at this moment he's actually not getting a lot, and current recommendations say you have to give a large amount of proteins. Diminish sedation when possible and increase passive active mobilization, or you do all the above. So who would choose for the first option? Nobody. Second option? So who would choose for the second option? No. Nobody? Sorry?
You two, I don't get. No.
No. We would choose only the third option. Okay. And we would say all of the above. The majority.
Okay.
Okay.
Another option, which is 1 and 3.
1 and 3. That might be like the fifth option. We would choose the fifth. We would choose the fifth option. Okay. Are there any other suggestions?
Just being difficult.
No, but it's nice. So we have interaction. Perfect. So no. So what we did, we only did 3. So why? Well, tolerating caloric deficits in the early phase, because we're still in the early phase. It's at day 5. It was elective surgery, so we know when the hit was initiated, lowers the incidence of muscle weakness and enhances recovery from muscle weakness, as was clearly shown by the paper of Geet Hermans. So in contradictory to normal physiology, actually not feeding your patients, so starving your patients, if you would say, actually is better for your muscle function, which is quite contradictory. And in a post hoc analysis, administration of the high doses of protein, so really high dose of protein, during ICU stay may have even a detrimental effect because it was associated with the severity of muscle weakness.
Well, as we already mentioned, if we look on nutritional therapy, it's difficult, and we have a lot of different parameters interacting with this, and this is how do we assess the nutritional need? There was a question, what kind of nutrition do we give, and how many calories do we give, and also what is the timing, early versus late, but for one do I start? So it is a difficult situation, and the data we do have, they cover all over groups of patients, but the answer would be just to individualize it and to be able to assess some of these components, like using indirect calorimetry, so on. However, there is a clear indicator that we don't feed our patients for 100%. This is from 2,700 patients from a study 2009, which clearly showed we don't give adequate calories and we don't give adequate proteins. 50 to 60%, this is what we do give. Well, now you can say we are doing all bad and we should give 100%. I'm not convinced by this answer, because if everybody is doing something like this in this direction, it does make have a sense, and I just want to go through pathology. Although it's clearly shown also in this study that increasing the amount of calories was associated to a better outcome. That's also clear. I'm not telling that we should underfeed our patients. I'm not telling that. However, we don't actually know what to do when, and this slide already has been shown. the EPINIC trial and BEAN trial, they did show, well, early substitution of feeding would not increase or would not have an impact on outcome. We have this trial, SVN trial, that shows, well, giving calories admitted regarding to indirect calorimetry, it at least reduces the amount of infection. So we have equivocal results. That is the problem. However, I do think, why do we have equivocal results? Because we have patients who are in, and we look on these patients in huge amounts of groups, but the patients are not the same. They may have sepsis, they may have sepsis syndrome, they may have septic shock, they may have recovered. And these are all data that already show that according to this amount of septic, the metabolic situation is completely different. And if we give all the same nutrition to all the patients, regardless whether they do have sepsis, septic shock, and or whatever, then we may run in the problem that we really don't hit or meet the needs of the patients. There's a clear discussion right now, and this is important to take home. Well, we want to avoid underfeeding, that is clear, and we have different pathophysiology behind underfeeding. However, on the other hand, we also want to avoid overfeeding. And autophagia is just a modern or just a parameter we look on, because overfeeding may suppress autophagia, and autophagia maybe is important to clear, maybe it's important to improve, for example, the situation in the muscle and the metabolic situation. If we again look on the studies we do have, especially on the EPINIC trial, this is a matter of discussion. Those patients in the early treated nutrition group, they were treated with kind of high calories. Maybe we had something of overfeeding. At the moment, we really don't know. However, if you look on it, avoid underfeeding, but also avoid overfeeding. Overfeeding is as bad as underfeeding. And again, this could be shown in the sub-analysis of these patients from the EPINIC trial, 60 patients, over 60 patients, and they looked on parameters indicating autophagia, and early high caloric nutrition suppressed autophagia. And we get to the understanding that suppression of autophagia is something what we don't have, although what we don't want to have, sorry. Okay, so it is a matter of the amount of calories, and the message to take home here, try to individualize it and avoid over and underfeeding. Well, we just wanted to take this thought, take up again this thought. Why do we do, and what is about diminishing of sedation? And you said, well, you would diminish sedation and give maybe as high as caloric feeding. Well, and the question is right. Why is this patient sedated? We really have to consider it, and it is an important issue. Sedation means immobilization, and we have clear data that even if you do early sedation within the first 48 hours, this is related to worse outcome. This is related to death, and well, we really can see, and we could. This was a small cohort of patients, I think 200 patients, and this was the same data we could show in about 1,000 patients, which were matched to each other with early and not early sedation. And it's clearly shown. Also, the long-term outcome, 700 days here, is influenced by early sedation. So, the real question in this context is also, it's not only nutrition, but it's also why do you sedate and immobilize your patient? And if you go back to the nutritional part and to the nutritional aspect, it clearly has been shown in this very nice study by Schweikert that having the patient mobile, early mobilization, and having the patient trained very early, that improves outcome regarding daily activity of living. That is clearly shown. And we also have, from a sub-analysis from this study, we do have the first data that show that metabolism is improving. Metabolism in regard to daily insulin dosage is improving if you do mobilize your patients. And we also, and we could show it in our own data also. At the moment, you do some sort of muscle activation to the patient, you are able to maintain muscle mass, and it does have something to do with glucose metabolism, as far as you are able to improve the translocation from GLUT4 to the sarcolemma. This is what we could show. So the answer should be, well, keep the patient awake as far as possible, maybe extubate him and give him non-invasive ventilation and have him active and have him able to do FIB therapy as early as possible.
Thank you. So
You have 2 minutes left.
we're almost there. So after 21 days, the patient was discharged from the ICU and recovered well. So some take-home messages, which may be room for discussion afterwards. Hypoglycemia is bad, so we should avoid that. Normal physiology is not applicable during critical illness. Tolerate a caloric deficit during the early phase of critical illness. This might be debated. Whatever you do, don't overfeed your patient. Always give micronutrients. We didn't went into detail.